Very good evening, everyone. We are here with yet another session on our platform On Your Growth. Today, we are here with Dr. Priyanka. She has completed her bachelor's in physiotherapy from D.Y. Patil College in 2012, and she has pursued master's in physiotherapy in musculoskeletal conditions from D.Y. Patil University. More than a decade, she has an experience in treating orthopedic and sports conditions, and she is also dry needling therapist, certified Mulligan practitioner, Mckenzie system practitioner, certified strength and conditioning training specialist. With this small introduction, I would like to welcome you on our platform. Thank you so much to come on our platform.
Thank you so much, Bhavit. So let's start with the presentation. I'll just like to share my screen.
Sure.
Perfect. So today's topic is going to be radicular pain and finding the root cause. So I chose this topic basically because here at Rise Network, where my clinic is in Mumbai, we believe in finding the root cause of the pain. So there are a lot of times that patients come to me saying that I have knee pain. With a history of, the knee pain is in lying down position, where actually the knee is not getting loaded, or the foot pain, dorsal aspect of the foot, where the foot pain is when the patient is lying down or when the patient is sitting. Okay, so these activities are not putting any weight on the knee or the foot. And then we try and understand, so where is this pain coming from? And that's where we realize that there is some other cause of the pain, and we need to find out that cause. So this is where the topic is coming from. So here at Rise Network, we believe in solving the mystery of the radicular pain. And me, being a spine specialist here, I thought that, giving you an idea or giving you a couple of tips that will help you to get to the root cause. So let's understand first what is pain. As we know the definition of pain, it's basically an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Okay, so what do you mean by emotional experience? Do you think pain has any psychological effect? I would say yes, because when there is a chronic pain, suppose it is for years or for weeks or for months, it does have a psychosocial factor that is considered. And that's why the definition also means that emotional experience. Now, when we say potential tissue damage, what do you mean by that? So when there is pain or when there is a tissue that is, that is basically has any damage or is injured, pain is something that is like a warning sign. So warning sign is just to prevent any further tissue damage. So it should be considered as a warning sign whenever, you have pain. It's a good sign, basically. Pain can be of different types. Here we are just going to concentrate on radicular pain. Now, radicular pain, as most of us know, is pain perceived other than the site of painful stimulus, which is mostly due to a nerve involvement, right? So this means that if the pain is coming from the disc or the spine from the neck, it can be somewhere around your arm, it can be somewhere around your fingers on the inner side of medial side of the fingers or the lateral side of the fingers, right? So but not necessarily it is in the pain can be in the hand, but not necessarily there is some problem in the hand, but it can be coming from the neck. And how do you differentiate this? This is what we are going to try and understand in this seminar. So if it is coming from the cervical origin, you can have pain in the arm, you can have pain in the forearm, you can have pain in the whole hand, right? Similarly, in the leg, if there is a lower back pain or problem, there is a lower back injury, or there is a strain, or there is a disc, you can feel pain anywhere around the leg till your grade 2, right? So that doesn't mean that the problem is somewhere local, but it can be somewhere proximal. And how to understand and differentiate that, that's what we are going to learn in the further presentation. The other thing that I just wanted to go through is anatomy of the spine. I think most of us are attending this presentation would be aware of this. So the orange color that we can see here is the spinous process. Okay, then the purple one is the lamina, which actually helps in attachment of the ligamentum flavum muscle, the ligament. The green one is the facets. The darker green is basically the pedicles, which along with the lamina forms the neural arch, and the transverse processes are in the red, which helps in muscle and ligament attachment. The body is the round color, gray color that we can see. Okay, the canal is what you see, the triangular area of the vertebrae, where basically the spinal cord will run through. Now, we all know that there are nerves that are crossing the the vertebrae. So, to just explain you about the anatomy, there is this model here. Okay, now you see the vertebrae are stacked on each other, right? And you can see the yellow part, which is coming right out of from the from the vertebrae, that is your nerves, right? So there are nerves that are, every vertebrae has that level of nerve, which just passes from the sides and it runs down to your arms or to your hand. Okay, other thing, what can be the causes of the radicular pain? Let's try and understand that. One thing can be the disc, okay, the herniated disc, which is just in between the two spinal vertebrae. So between the two spinal vertebrae, as you can see, there is a white color disc, which helps in shock absorption and works as a cushion. Whenever there is a disc, herniated disc, or when the disc is come out of where it is supposed to be, it compresses on the nerve that passes on the sides of it. Okay, so you can see the B image. It shows that the disc is impinging on the nerve. When the nerve is impinged, you can feel the symptoms down the legs or down the hand. The other cause can be stenosis. Now, what do you mean by stenosis? Stenosis is when the spinal canal diameter is reduced. It can be because of ligamentum flavum hypertrophy, where it it comes in the canal and it pinches on the spinal cord, or it can be because of a chronic disc or osteophytes, degenerative changes as we see. Spondylosis. Okay, these osteophytes will keep impinging on the spinal canal and can cause radicular symptoms. Spondylolisthesis is when there is a slippage of the vertebrae with respect to each other. It can also cause nerve impingement or nerve involvement, leading to radicular symptoms and, of course, fractures. Scoliosis is something that can be degenerative or postural. It is basically if you see a spine from the back, you will see the spine to be straight. In scoliosis, the alignment of the spine or the curvature of the spine can change. This can cause a little wear and tear in the spine, leading to osteophytes, or some part, the concave area can be compressed, and that can lead to impinging or crowding of the nerve, leading to radicular symptoms. Okay. Next is, so all leg pain is not nerve root pain. We need to understand that if at all a client is coming to you saying that I have bilateral foot pain, or I have bilateral knee pain, not necessarily it has to come from the knee. It doesn't have to come from the nerve. It can be actually coming from the knee joint as well, right? So we need to try and understand, how do we differentiate if it is a nerve root pain or it is something local. So how do we differentiate is by understanding the dermatome, right? Dermatome is the area of the skin that is supplied by the nerve fiber. So every nerve fiber has some area in your this area of the skin that is supplied by it, right? So C2, C3, as you can see in the diagram, C2, C3, C4, C5, C6, C7, C8, right? Okay. So So what I want you to understand is you can check, what you have to do is basically learn this diagram and try and understand the dermatome. You have to just by heart it. But these are very important when it comes to examination, because without doing an MRI or an X-ray, you can actually understand where is the problem lying, which spinal segment is the problem that the client is complaining of. Myotome is another thing. So group of muscles, myotome is nothing but it is a group of muscles that are innervated by a single nerve root. So these muscles, when we do IMT or when we do MMT, that is the manual muscle testing, we try and test these muscles, whichever are innervated by the spinal nerve, and understand which nerve is affected or which nerve is getting pinched. So this is also something that you will find online, the diagram. You just have to by heart it. Suppose like if a patient coming to you saying that my grip strength is weak, okay? So you need to check and understand what are the muscles that are helping you in grip strength. So C8 is the nerve root that is, is the problem causing nerve root. So we can actually come to a diagnosis without an MRI and X-ray and just by your clinical examination. So the other symptoms that we can the symptoms that we can see in a radicular pain is radicular symptoms is one is pain. Pain can be anywhere. You can have pain as we discussed with the dermatome. Dermatomal areas can be painful, pins and needles. You can have numbness. You can have burning sensations. So these are classical signs of nerve root. Right? Motor, you can have weakness. If there is a chronic pain or if there is an acute impingement, you will have weakness seen in particular muscles, myotomal muscles, and reflexes can be involved if there is a spinal cord involvement in that. So are there any diagnostic tests? Yes, I would say there are a lot of diagnostic tests. I think the first thing that people go to when you have a disc pain or when you have a back pain or a sciatica, as rightly said, radicular pain is called as sciatica, you go for an MRI and X-ray. But believe me, that is not the only solution. Your history. So when clients come to us at Rise Network, we believe in taking a thorough history, understanding what are the factors that are causing worsening, what are the factors that are aggravating, what are the factors that are relieving the symptoms. And from that, we can understand the directional preference for the patient, what direction the patient is going to, what exercises or direction the patient will need exercises in. Especially when there is a disc involvement, coughing is something that will trigger the pain. So make sure you are asking about does cough increase the pain or sneezing will increase the pain. Age is important again in case of stenosis. The lifestyle is important, working style, or how many hours in a day they are working. If they are working out in the gym, then are they doing their warm up and cool down properly? Because that can lead to a lot of pressure on the disc. So all these small things are very important. Again, apart from this, other factors like water intake, D3, B12 is also very important, because sometimes when there is a B12 or D3 deficiency, you might feel little tingling, pins and needles in the leg or in the hand, right? And it cannot be matching with the dermatomal pattern. So in those cases, you need to understand that you need to also look into your vitamin deficiencies. Physical examination, I do believe a lot in physical examination, movement analysis. We basically, here we make sure that we are not seeing the MRI X-rays, and we try and understand with movement analysis, that is checking the movements of the back, checking your understanding the spinal movement, and then trying to figure out which area of the spine can be involved and how we need to treat with, how we need to deal with that. So movement analysis is something that you check doing the movements of the back, like you do flexion, extension, you do side glide, and you check if the symptoms are increasing or if it is reducing. Tightness is very oftenly seen when there is a back pain. You will see the gluteus maximus going into tightness. piriformis going into tightness, the erector spinae going into tightness. So you need to understand when and how to deal with that tightness. So generally, when you understand there is tightness, and in acute cases, when I say acute, I mean that if the pain is within 48 hours or 3 to 4 days, you will not try and relieve this tightness. You will just try and keep the tightness there because it's like a protective spasm, right? So examining this tightness is also important. Other neurological testing. So if there are radicular symptoms, there is tingling, numbness, we do neurological testing like checking the sensations, checking the strength, IMT, MMT, manual muscle testing, SLR, straight leg rest to understand if there is a nerve involvement, and then we come to a conclusion. Apart from that, definitely, if none of these are helping you and you're not reaching to a provisional diagnosis and differential diagnosis, an X-ray and an MRI will definitely help. EMG, NCV is EMG, as we rightly know that it is just to test the how healthy your muscle is, and NCV is to test how healthy your nerve is. This is done in extreme cases when there is weakness, or if the patient is not able to lift the foot, not able to wear the chappals, or if the grip strength is weak. So in these cases, we check the EMG, NCV testing. Okay, so the treatment plan, we work a lot on core strengthening. When I say core strengthening, these are not your six-pack muscles. These are not your superficial muscles. These are the deeper core muscles, which is called as transverse abdominis. You work on these muscles. You work a lot on obliques. Initially, you start with basic exercises, then you move on to the intermediate, and then you move on to the advanced exercises. Hip strengthening exercises, glute strengthening basically is an important part of lower back pain rehabilitation because those are the stability muscles for your back and will take off the load from the back and help in all the functional activities. Here at Rise Network, I practice a Mckenzie system, which is Mckenzie technique, which has specific exercises for the spinal issues. If anybody is interested to know more about it, they can get in touch with me. I can help you understand that. But it's a vast study which has I have done a lot of courses for that, and then we are practicing it here. Other than that, passive treatments like taping or dry needling does help, but it needs to be followed by active exercises. These are just temporary solutions, taping and dry needling. It will help in temporary reduction of pain, but we work a lot on active exercises so that the stiffness or the strain on the back should not come back again. Okay, so radicular pain is definitely real. We have a patient, Swanan Court, who's volunteered to share his experience. So I would just like you to hear what he has to say. Let's start with the history, what history he basically came up with when he had the pain. Let's try and understand that. So basically here, what I want you to understand is the pain actually started from the back, right? And then it started radiating down the leg. So this is the most common history that the people, your clients or your patient will give you, that it starts from the back and then it goes down the leg, okay? So try and understand that. So that's why we focus a lot on history taking. So make sure you're not missing on these. Again, one more thing, he said that coughing may the pain used to increase, right? So this is the second thing that the patients will complain. Now let's go to the other things. Complaints. So what complaints? Yeah. Yeah, so basically, when initially he came to us, he had hamstring, he had posterior thigh pain, he had the calf pain, and the back pain was not there. Okay, he started with the back pain, but later on the back pain went, and the hamstring and the calf was giving him pain, which is actually a condition where the back is getting worse, right? Because the pain is traveling distally down the leg. So that is when on thorough examination, we realized that it is not any local, it is not a hamstring strain or it is not a calf tightness. It is definitely coming from the back. And then we went to a diagnosis. So let's hear what he has to say. Let's hear what he has to say here. Yeah. So for him, basically with movement analysis, we understood that when we are doing some back movements, the pain is getting altered, right? So we found out the differential diagnosis. We found out the directional preference for his back exercises. We started doing the back exercises and his distal symptoms started reducing. And that's when we realized that it is coming from the back. So to understand and to rule out the local causes, you need to do a thorough physical examination. Don't rely on MRI and X-rays. You first do your physical examination and then reach to a diagnosis. If there is any doubt, or if in 2 weeks you're not able to understand the directional preference or the symptoms are not coming down, then we can suggest the patient MRI or X-ray. Perfect. So that's it from my side, Bhavit.
Thank you so much. I have a few questions if I can proceed with that.
Yes, of course. Yes, yes, yes.
Yeah. So how do you integrate these patients with first, how do you convince for your therapies, and what would be the time duration you have to explain to the patients regarding your therapies or your treatment procedures to them?
Yeah. So convincing, we actually don't have to. So it's not about convincing, it's about showing your results, right? So when a client or a patient walks to me, we, after the examination, okay, finding out the directional preference for the back issue, we make them do the exercises here. And then we again check the movements that are giving them pain, right? So it's before and after testing. So once you do that, and after a particular exercise that is relieved, after doing a particular exercise, if the symptoms are released or if the pain is reduced down, they themselves are very convinced that okay, this treatment is going to help. right? So it's all about showing through your actions, showing through your treatment that this exercise is going to help you. And I actually don't have to convince them through words. It is just through exercises that I make sure that they are convinced. That is one thing. Other to answer your other question, so generally what I do is if there are extreme symptoms like there is a radiating pain or there is tingling or numbness in the leg, I tell them we'll watch for 2 weeks. Okay, we'll watch for 2 weeks. We'll see if there is if there is 10% reduction in symptoms, then we will continue physiotherapy, and then it goes on for anywhere between 6 to 3 months, because back is something that is like a base of your body. So it takes time to strengthen, it takes time to achieve their goals for back pain. But I watch it out for 2 weeks. If there is no change in the symptoms, then I have to refer them back to a spine specialist, or maybe do further investigations to try and understand what is the problem. But otherwise, we continue with physiotherapy sessions for at least 3 months.
So as we thank you so much for this answer. Detailed elaboration is there, but there is like when you see your profile, there are so many practitioners like certified Mulligan, Mckenzie system. So how a student can learn these techniques or go through these techniques, and what are the procedures or what are the places where they can learn these kind of like they become practitioners of these
Right.
specialization.
Right. So these techniques, I mean, if people who are still studying or are still pursuing their education, I think these techniques are already taught in our basic academics. But to have a depth knowledge about it, and if somebody is keen to know about Mulligan, then there are different instructors who teach Mulligan. For Mulligan, I think Dr. Deepak Kumar is the best. Mckenzie, there are different courses, or there are different instructors which are if even if you Google Mckenzie technique, I mean, and if you want to do a certification or a course, you can you just have to Google and you will know about it. I think people who are pursuing physiotherapy or in academics, we do have a brief knowledge about all these things, but to study in depth, you need to do these workshops and seminars differently. Not it's not basically in-depth knowledge in your academics. Anything else, Bhavit?
Am I audible to you?
Yeah, now you're audible.
I was trying to connect with you. So what would be your like final like kind of a message to all the doctors who wanted to pursue and give the integrative approach from all these therapies?
So, my message, I mean, if you want to pursue physiotherapy, it's a great field, but all that you need to understand that you need to you need to believe in yourself. You need to make sure that you are giving your best service to the clients. You have to follow your ethics. Make sure you're using technology which are beneficial to your clients, to your patients. And it's no more like you have to be selfless and give your 100% when you have a client or when you have a patient. You have to be selfless. Yeah.
So with this, we would like to end our today's session, and thank you so much because we have learned so many things and understood the mechanism. What is a plan of action from your perspective, and it brings an approach where all the doctors can think of that how many things, how many practices are there which we can apply through all these things. So the integration of multiple therapies with other system of medicines would bring a good holistic approach for a patient. And that's what we learned from your session. So thank you so much to come on our platform and share your insight with all of us.
Thank you so much, Bhagat. Thank you.